Okay, welcome everyone. So today we have Dr. Daftary, who's going to be speaking to us about under-5 mortality. And I have to say, again, this is one of my favorite talks. It gives us an overview of the under-5 mortality, and also just hearing your career path, Raj, is always really inspiring. So Dr. Daftary is a pediatric emergency medicine physician, associate professor here at UCSF, and actually a long friend and colleague, and we've overlapped in Tanzania before. He works in quality improvement, medical education, and yeah, today we're going to hear about under-5 mortality. Thanks, Raj.
That's great. Thank you, Teresa. And hopefully you all know Teresa's backstory and her career path, but so inspiring. I'm just thrilled to be here. So as always. So thank you for the introduction. We're going to get started. I'm going to do things a little bit different. I took feedback from past years and really focused on the back half of this presentation because I think that's the most fun and really where there's a lot of cause to be optimistic. And I also want to get to know all of you a little bit more. So this actually plays a little bit into how we're going to talk about this because it helps me know kind of where your interests are and what I should focus on. But if you could in the chat, and by the way, this is probably the only time I'll be looking at the chat. So just please interrupt me anytime. I really appreciate an interactive conversation. Feel free to take yourself off mute and ask me any questions that come up. But for the time being, in the chat, if you could just type up what maybe your dream job might be. It doesn't have to be a specific role, but maybe what you might be doing in that job. And then kind of a grim question, but how many children under the age of 5 do you estimate die worldwide each year? And I'm gonna wait for at least 10 responses. Put the pressure on. Okay. Great thing about being an astronaut is there are many pathways to becoming one. So I hope that's in your future. Adria, that's music to my ears. Let's talk. Hopefully I can support in any way. And no EHR. I don't know if I can help with that. Okay. I love that answer, Teresa. And a cutler. Oh man, never considered that. I would pay to do that. Okay. Some really good answers here. I love that one too. Yeah. Okay. All right. So we're going to spend a lot of time talking about that number in particular, and really appreciate, especially kind of your interests professionally. Again, let's customize this conversation to the things that are of interest to you. So interrupt me anytime. I need to say this, I don't have any personal financial relationship or conflict of interest identified. And just a little bit of background. So Teresa told you a little bit about what I do right now. So between residency and fellowship, I spent almost 2 years working in the southern African country of Lesotho. It's landlocked by South Africa. It has a population of about 2.1 million. It experienced a population decline right in the 2000s due to the HIV/AIDS epidemic. And the time that I was there, it was the third highest in terms of incidence in HIV in pediatric cases. So my work there was working to scale up HIV care delivery to pediatric patients and also to work as a pediatric hospitalist. You'll see in the lower right-hand corner, that's the National Referral Hospital, Queen Elizabeth II, that was functioning at that time, and where I spent the majority of my clinical time. Since coming back, I've done a PEM fellowship. I've worked as a PEM attending now for 11 years. And most recently, I've been working in the role as medical director of the ED at Children's Oakland. And that is another kind of dream job in that a lot of the things that I've learned in a global or a international setting, I've applied to some very similar challenges here. And my work continues, albeit in a different kind of lens. It's about getting care out to our rural communities right now, understanding their needs, and then hopefully being able to apply some of the lessons and applications that we've developed here to a more global setting.
Sorry
So,
to interrupt, Raj.
yes.
I think we may have accidentally unshared your screen.
Oh no.
Wouldn't mind resharing your.
Yeah. Okay. You should see a slide that says "Don't miss the forest for the trees." Okay. So I like to think about big picture, and what I want you to take away from today is 4 points. So, too many children are dying, right? And we could argue that a death of any child is a tragedy, and I firmly believe that. We can also make the argument about what it means to deliver with the care resources that we have. And what I'll tell you is that we have slowly seen improvement in child survival, in reducing mortality. And one of the reasons why is that we have solutions. And one of the things that's really challenging also on the flip side is that we're not great about delivering the solutions to where they need to be. And so one of our main challenges that we are seeing right now is around implementation. We're going to be talking about today, we're going to define child mortality, understand the scope of the problem, understand that there's disparities within that problem itself, and identify what are the things that contribute to it. And then finally, we're going to talk about interventions and effectiveness. Now, at a later point in this, we're going to have some interactive portions. And so it would be super helpful if I could have 2 volunteers. It's going to be pretty low key, but 2 volunteers to take us through. You're going to need to share your screen. We're going to ask you to open up a browser, and we're going to walk through an exercise together twice. And it would be great if I have volunteers at that time. Okay. So the question is, why do we focus on under 5? Well, first, to define it, under 5 is the probability of child death. And that is essentially the number of children that are dying before their 5th birthday per 1,000 live births within a region. And then if we further define, if we dive down a little bit deeper, so neonatal mortality is talking really about the first 28 days per 1,000 live births. Okay, so 5th birthday and 28 days. And if you look at this graphic, there's a report, the 2023 report that I used quite a bit when I updated this lecture. And some of these slides are just really wonderfully demonstrative of the problem and why we focus on these particular things. But if you were to look at the far right-hand bar, you'll see that there's 2 blue sections, right? And if we compare deaths in 0 to 5 versus 5 to 24, what we would consider older children, adolescents, and young adults, you'll see that the absolute number is twice as high. So in 2022, about 4.9 children died under the age of 5 compared to 2.1 after, in that significantly longer span of time. And the causes of death in under 5 and the vulnerability is different than after 5. And so that's why there's a particular focus that we pay on this, pay to this particular group. Just to walk you through a little bit of timeline. So we're going to jump around a little bit, okay? I had mentioned that things were tough. So for those folks who entered in the chat, the most recent numbers look to be about 4.9 million. All right, so 4.9 children under the age of 5 died in the year 2022. Now, if we think about just from survival statistics in the 1800s, and I'm going to talk only about the United States for just a second, okay? In the 1800s, our under 5 mortality was in the 400s per 1,000, meaning about 40% of children didn't make it to their 5th birthday. By the 1900s, the early 1900s, in the United States and many economically advantaged countries, that number had started to decrease to about 200 per 1,000. And between the 1900s to 1960s, that number was halved. And that was largely in economically prosperous countries, but also there were some advances made in those less prosperous countries, what we would consider, or what has been named as the developing world. The under-5 mortality rate was 200 per thousand in the United States, and it dropped to lower than 80 per thousand. But worldwide, around 1960 to 1990, it shifted to about 93 per thousand. Now, in 1990, 2.4 million children were dying, right? And that is much higher than where we are right now. And I'll show you some comparisons, but 2.4 million versus 4.9. We were seeing some pretty significant inequities where the under-5 mortality was even higher than that 93 per thousand. In 1990, there was a convening of countries at the World Summit for Children. They set a goal to say, we're going to reduce by 1/3 to get to a goal of 70 per thousand, or decrease by 1/3 per region. And we want to do it within 10 years. They didn't make that goal. They came close to it. In 2000, that number was around 90. Excuse me, not 90, it was around 75. So it was 75 per thousand. And there was an acknowledgement that there was significant improvement, but it hadn't gotten to where it needed to be. So then an even more ambitious goal was made that said, hey, we're making progress. We're going to write into our charter with the Millennium Development Goals that we're going to reduce under-5 mortality to about 30 per thousand. And they wanted to achieve that by 2015. So in 2015, we took a look at the data, and it showed that we got to about 43 per thousand, right? So again, we didn't hit the target that was laid out, and yet it was a significant reduction, okay? At that point, there was the introduction of the Sustainable Developmental Goals, which is kind of the next chapter of this, and we'll talk about that in a second. But the point is, we've gone from, within the span of about 100 years, a little bit more, from 200 per thousand in one of the most economically advantaged countries to worldwide 43 per thousand. So that was a huge improvement. This is a slide that's showing basically what the absolute numbers have been in terms of overall deaths. So from 1990, we went from 12.4 million, slowed down tick to eventually 4.9 million. However, if you look and see kind of the total number of deaths between 32 years, it was 278 million children. That's the entire population of Nigeria. That is children under the age of 5 that have died within the span of 32 years. If you look at this graphic, those larger, darker bars indicate deaths between 1 and 59 months. And then that smaller bar per year is neonatal deaths. And you'll see that that number doesn't change as much as it does for the 1 to 59 months. And we'll talk about where there's some differences and why those differences exist. Okay. Any questions so far? Okay, stop me anytime. So now I want to talk to you about disparities. So we know that there are regions, though we're going to call them resource limited settings, or what we call developing countries, where the proportion of mortality is higher. And you'll see 3 color bars per region, and those indicate 1990, 2000, and 2022, what their overall mortality rates were, right? So if we compare sub-Saharan Africa, in 1990, that mortality rate was about 181 per thousand versus worldwide 93 per thousand. And you'll see that this general trend persists, that these 2 particular regions, sub-Saharan Africa and Central and Southern Asia, have higher rates overall than worldwide. Okay, so when we think about overall mortality, we know that there's a disparity here. We know, in fact, also that about 68 countries, that's where there's a larger burden of child mortality that account for about 97% of child deaths. And if you were born in a low or middle income country or reside in an LMIC, compared to a high income country, your likelihood of death is 18 times higher. With an awareness towards this, I had mentioned the Millennium Development Goals, and that came out of a declaration by the United Nations. And I would just want to read this word for word because I find it inspiring. But it says that every individual has a right to dignity, freedom, equality, and a basic standard of living that includes freedom from hunger and violence and encourages tolerance and solidarity. So really bringing out the best of what we would perceive in humanity and our ambitions, our shared ambitions, and what we would want for each other. That was in response to what was happening at that time in 2000. So each one of these dots represents a child death under the age of 5, represents, 5,000 child deaths under the age of 5. And so just if you could take yourself off mute, if someone could just volunteer for me, what stands out to you about this particular map in 2000?
In Africa and like India region that you see most of the dots, and there's a lot of areas with no dots.
Yeah, great point. And let's take it a little bit further. This is a little bit of a test of geography. So you mentioned India. So what is it about India and that particular region within Africa that maybe correlates to the number of red dots?
Some of the highest populations of the world.
Absolutely, right? So that's Nigeria, that's India, right? So those are very densely populated areas. So this is, when we talk about child mortality, I want you to think about two concepts, right? Or two ideas. One is about mortality rates, right? Likelihood that you will die or that a child will die, right? And then also talk about absolute numbers, right? Those are two parts of an equation. And also as we think of resources, right? A country that is a very high population, the resources required to reach every member of that population is going to be different than one that has a lower population. Also, population density, it has a different impact in terms of how you deliver certain healthcare interventions. Okay, so keeping that in mind. So I want to just show you, this is 2022 data, right? And so this is the under-5 mortality, and you'll see that there's some overlap, right? You'll see that Nigeria is still highlighted here. It has some of the darkest color, but you'll see that so some of these other countries in Western and Central Africa, so Niger and Chad, you'll also see Somalia, and then within Southern Asia, you'll see that Pakistan and Afghanistan are still within some of the dark colors. And this is just a table that shows you in 2000, right? So these are total number of deaths for some of the countries that I mentioned, the 5 highest in terms of absolute total deaths, and then probability of deaths. And you'll see that there's not a ton of overlap within these two sides of the table. Anyone want to comment if you can think about what was going on in 2000 with probability of death in those countries on the right-hand side? Maybe someone who hasn't volunteered yet.
Would that have been around the time of like the Afghanistan war and other
That's right.
conflicts?
Right. So conflict, right? So conflict and political stability play a role in this, right? So I'm going to bring out a term. So fragile and conflict affected situations. So this is a term that's used by the World Bank, but essentially the definition is those areas that have political or social instability or a high number of violent deaths. And FCS countries in 2022, the under-5 mortality rate was 73 per thousand, right? And compared to non-FCS countries, that number is 3 times higher. So there's a significant impact in terms of what's happening within a social situation, with what's happening within a political environment that affects delivery of care and access to resources for children in particular. So children are uniquely vulnerable within these contexts. This is just showing some progress that has happened between 2000 and 2017, how there's been reductions in the absolute numbers. Nigeria was a little bit slower to make movement between 2000 and 2017. We'll talk again a little bit about that. But the overall theme of the conversation today is that there is progress that is being made, that can be made, and needs to continue. Okay. So now I want to shift a little bit to talk about, we've talked about what the scope of the problem is, right? Let's talk about what are the underpinnings, what are the causes of it. So this is a slide that's taken from, and I'm going to mention this later on, but the Lancet publishes a series every year about global child health. And then every other year, they provide a significant update. And so you can see these wonderful summary slides. This is taken from something that was published in 2022, referring to 2019 data. And so right away, you'll see that there's a split in this pie chart. And you'll see on the right-hand side, the number of the proportion that's from neonatal deaths. And on the left-hand side, you'll see the proportion of deaths for after 28 days. And again, we'll talk about this, but I think it's really significant that a huge slice of this pie is for children under 1 month of age. What you might see if you're able to see the level of detail on this particular slide is that infectious etiology is a major cause of death, especially for children who are older than the age of 1 month. So that's pneumonia, diarrhea, and malaria. In the neonatal period, they're slightly different. There is infectious causes such as sepsis and lower respiratory tract infections, but also there's complications related to preterm birth and intrapartum complications. This is another slide that talks about the impact of access to resources. So on the left-hand side, you're going to see something that's called the sociodemographic index. All right. And that is a composite measure of income, education, and fertility for a region, with 1 being the highest and 0 being the lowest. And what these colors represent is a particular disease and the proportion of overall mortality that's caused by that particular disease on the right-hand side, and on the left-hand side, it's the rate. So it's a little bit of a confusing chart, but if you just take a moment, there's a lot of data. This is a really rich slide that you can take a lot from. And what you'll find is that on the bottom of the SDI, you have very high rates of infectious causes, where as you move up, those infectious causes start to drop away as proportional reasons why children under 5 are dying. And instead, you have the introduction where the absolute numbers are low for overall mortality. You start to have the introduction of congenital conditions, for injury, things, and non-communicable diseases. So all this to say is that the problem is not the same in every particular region. And I don't think that's quite a surprise, but to see it illustrated like this, I think is pretty stark. Again, this is another point to be made to say that the problems aren't the same, right? In those areas that have very high mortality, it tends to be, those major causes tend to be from infectious. Whereas if you move to those areas that have very low mortality, typically these are what we call developed regions or regions with access to resources. It tends to be from problems that are difficult to tackle in a different kind of way. So congenital abnormalities and preterm birth, but also there's the presence of injuries. This is talking about regional variation. So even within resource-limited areas, Southeast Asia versus Africa, the absolute number is different. Also, the number of and the proportional, the proportion of neonatal deaths is different. We could spend a little bit of time studying this, but I think that the take-home that I want you to know is, again, any solution that we propose really needs to have a clear understanding of what the upstream causes are, what the problems are, and in knowing that, then you can pick what the intervention is going to be. Okay. And then one thing that's a little bit difficult in all of these reports and all these slides is to really understand the role of malnutrition. When I was working as an inpatient hospitalist in Lesotho, I would say about 40 to 50% of the patients that we admitted were at least moderately malnourished, meaning they were at least 2 standard deviations off of what was the expected for their height. And so if we look, and this is based off of data in 2000, we found that malnutrition was concurrent in about 53% of all deaths. We knew that if you were at least mildly malnourished, it doubled your risk of death. And if you were moderately to severely malnourished, it increased your likelihood of death 5 to 8 times. And you can see in particular with infectious causes of death, there is a strong correlation with malnutrition and those causes. I want to shift now to neonatal mortality. I talked about how this is a slightly different problem. And what's a little bit challenging about it is that we're talking about a span of 28 days. And you can see that within this bar graph, if you move left to right, this is days of life, your daily risk of death. And you can see that it's highest within the first 24 to 48 hours. In fact, the first 24 hours, sorry, I thought I had a comparison number here, but your highest risk is at the 24 hours, and then there it is. So the first 28 days, day for day in your first 28 days compared to the next 1,800 days, there's a 30-fold risk of death in many of these regions, especially in low and middle income countries. This is the slowest rate or slowest group of mortality that we've been effective in reducing. There's one of the reasons why is there's many causative factors. In particular, healthy pregnancy has a strong correlation with survival in the neonatal period. And so addressing maternal health is one of the major ways in which we can improve child survival. They're interlinked, and I'll show you a great slide on that in a little bit. But essentially, maternal mortality continues to be a challenge in many regions worldwide. There's about 500 deaths per year. And the lifetime risk in some regions, and I'm going to say this really slowly because I want to make sure it lands. In some regions, 1 in 10 women will die in childbirth. And that doesn't mean in a particular pregnancy, but during any pregnancy in their lifetime, 1 in 10 women will die in some of these regions. A massive number. Neonatal mortality, we've talked a little bit about this. So preterm and peripartum, so things such as asphyxia or hypoxic ischemic injury are some of the major causes of poor outcomes. And low birth weight infants have worse outcomes. So prematurity, maternal health, I've already mentioned, and intrauterine growth restriction all play a role in overall health of the newborn. Sometimes it's hard to think about what's happening in the rest of the world that can feel abstract. Sometimes it helps to have a little bit of a comparison. So for that reason, I'm offering some limited data on the United States. What I want to show you is this is taken from a 2017 slide from the CDC, which basically shows you the ranks of major causes of mortality by age group. At the time, in 2022, our under-5 mortality rate was about 6 per thousand, which accounts to an absolute number of about 23,000 deaths. The majority of deaths in ages under 5 are injury, congenital, and non-infectious. And I've circled in red kind of where on this table infectious causes land. And you'll see that they're kind of in the lower half, starting at number 6. Okay, injury is a major part, and congenital anomalies are another major part of death in children under the age of 5 in the United States. Here's another comparison slide. This is from a really interesting website called BizHub, and I'll share you the link with you. It's there as a citation, but I'll share it with you in a little bit. But it's interesting to play around with. Red causes tend to be infectious causes, blue causes tend to be non-infectious causes, and green tend to be from injury and what I would consider like surgical related events, such as a foreign body. So you'll see globally, disproportionately, how much of overall mortality and the burden is from infectious causes versus non-infectious, versus in what we're going to call a resource-rich country such as the United States. It tends to be less infectious, and then the introduction of injury like we talked about. Again, more comparison. I'm not going to spend a lot of time on this, but you can see that there's a frank disparity between what's been labeled the developing world and the developed world, or more specifically, where resources are. Okay, so let's bring this back. So in our current day, we're operating within the framework of the Sustainable Development Goals, which were published in 2015. And rather than having a limited set, the Sustainable Development Goals are now 17, and they have subheadings. And this falls under 3.2. So 3.2, the goal is to end preventable deaths of newborns and children under the age of 5. Notice it's not, we want to eliminate it completely. We know that's not entirely practical right now, but preventable deaths. And what that would mean would be to bring down the rate under 5 mortality to about 25 child deaths per 1,000 live births, and specifically for neonatal mortality to bring that down to about 12 per 1,000 live births. Where the reductions have happened so far in the past has been mostly through reduction of mortality from infection, diarrhea, lower respiratory tract infection. So there's a lot of progress. There's still progress that can be made. This slide just points out that there has been substantial progress, and this is where it's been done so far. Okay, so now we're going to get to the part where I want you to feel empowered to know that there are solutions out there to think about as you craft your future careers and your role in global health, what your role might be. Okay, so we're going to do an interactive exercise. This is my first time doing this with Zoom, but we're going to see how this works out. So I'm going to show you one of my most favorite graphics taken from literature. This was published back in 2000. And what this is going to show you is problems and what the possible interventions would be. And what I'd like you to consider is which of these interventions may address a major cause of mortality. So I'm going to ask you to, if you take your cursor, you should be able to do this and hover it over this window, this slide. On the left-hand side, you should see a set of tools that allow you to annotate. If everyone could just hit I think there's a pencil icon. If you could hit the pencil icon and just annotate directly onto this, where you think an intervention, yeah, Jasmine, I see a check mark. If you can just mark where you think an intervention might be effective against a particular disease, a major cause of death, and the major causes of death, again, are at the top of this slide on the x-axis. So let's just take a couple minutes. Hopefully this will work. If it doesn't, then maybe type in the chat or think to yourself what might be an effective intervention. I'm gonna give it 10 more seconds. I love this. This is so wonderful. This is my first time doing it this way, and it's really fascinating to see this. So first off, great job. I'm going to show you what the slide looks like in just a second. But does anyone have any, just based off the group's own work here, does anyone have any observations right now? Anything, does anyone find anything surprising about this?
I think, I mean, to throw out there that just something like breastfeeding seems like it's a relatively simple like public health intervention, but look how much it affects. So any of these like large scale public health wash interventions or nutritional interventions really have like a broad spectrum of diseases and infections that they help combat.
Yeah, that's absolutely it. Thank you, Teresa. All right. Oh, okay. I didn't actually, I love that this just happened. I didn't realize this would happen, but you can actually see your markings are going to carry over to the next slide. And you can see you're pretty right on with a lot of this. So this is what the slide looks like. And before you remove your annotations, I'm going to ask you to do that in a second. What I love about this slide, the reason why I get so fired up about this slide, I'm sorry, it's from 2003, is it shows you on the top major causes of mortality. And what it also shows you is that there is a solution, evidence-based solution for every single one of these problems. And as Teresa just pointed out, some of these are not, in fact, most of these are not technology intensive, right? Breastfeeding, oral rehydration therapy. One of the other things that's really interesting is that one intervention may have an impact on multiple disease processes. And I'm going to show you some conceptual models in just a second that get me personally really fired up. And hopefully we'll get you fired up too. All right, if you could do me a favor, thanks. I don't know how you all did that at the same time, but great. All right, so this was again from a Lancet meta-analysis, and it just kind of points out, and this is old data. This is 20 years ago, that points out that there's evidence for each one of these major problems. Okay. All right, this is now we're going into like what I consider mind-blowing territory. I just think this is the coolest thing, and I love sharing it every year. So this is a conceptual framework that was modeled out of a group in Hopkins, or at Hopkins. And basically what it shows you is in the left-hand column, interventions. In the middle column, it shows you risk factors. And in the right-hand column, it shows you causes of death. And I'm going to share the website with all of you in just a second, because I want you all to play with it for a minute. And we're going to use this tool to talk about particular interventions. Okay. One that I think that we really should spend a lot of time thinking about from a global health standpoint is breastfeeding. And when we talk about breastfeeding, there's two ways to think about it. There's exclusive breastfeeding. That term indicates that there's no additional food supplementation. There's no solid food introduction for the first 6 months of life. And that exclusive breastfeeding starts early, right? So it starts within the first hour post-delivery. As of about 20 or 30 years ago, our exclusive breastfeeding rates in many parts of the world were between 10 and 20%, right? To meet all of these criteria. And there's a huge amount of variation country to country. And there's a cultural component to it, right? There's a messaging and a public health component to it that have all been a part of the challenge around this. The second portion of breastfeeding I want to talk about is what happens after 6 months. So it's complementary breastfeeding. So we know there are benefits to mother and child to doing prolonged breastfeeding after 6 months of age. And so even after the introduction of solid foods, to continue on with breastfeeding at least until 24 months of age. Okay. So using this, the list tool or the live save tool, what this conceptual model, what I want to show you, if you can see my cursor, is that breastfeeding promotion can increase your early initiation of breastfeeding, which can decrease neonatal mortality. And we can speculate the number of reasons why. The evidence will kind of bear this out, right? But if we're providing maternal antibody that can reduce infection, if we're not introducing new food sources that may be vehicles for infection, we're going to reduce the incidence of sepsis. But you can also see how the arrows point to multiple other things, right? So pneumonia and diarrhea, this is all talking about incidences, right? But then it also talks about diarrhea incidence, stunting, your overall nutritional status improves. So as our nutritional status improves, as stunting decreases, which is another term that's used to describe nutritional deficiencies, as stunting decreases, your incidence of these major causes of death decrease, right? And so then your overall mortality decreases. And sorry, I missed a point. So this is really outlining neonatal death. This is talking about childhood death, right? That 1 to 59 months. But you can see that breastfeeding has an impact in all of these age groups from birth to 5 years of age and in multiple disease processes. So as we saw in that last exercise where we kind of ticked the boxes, how multiple disease processes are impacted by a single intervention, this is the conceptual model that demonstrates how, okay? Questions about that? Great. All right, I'm going to go to just a few more interventions just to talk about how this model plays out. So let's talk about just vitamin deficiency or even using particular vitamins as treatment. So vitamin A is a treatment for measles. It's supplemented when caring for children with malnutrition, and it reduces the incidence of diarrhea. Zinc also reduces the severity of diarrheal illness. And in children who are micronutrient deficiency, treatment with zinc can decrease the severity and duration of a diarrheal illness. So this is, again, the model showing very similarly. And the theme, I think, to bring out in this is your health status prior to an illness is a predictor of whether you will survive that illness, right? And so not having a deficiency decreases the impact of a particular illness, but then also supplementation can have a role in treatment itself. And the same holds true for zinc, okay? Zinc for treatment, zinc for supplementation can reduce death from neonatal diarrhea, also from childhood diarrhea, meningitis, measles, pneumonia, okay? All right, so now I need a volunteer. I'm gonna, in just a second, I'm gonna stop sharing my screen. And I'd like someone to go to this web address, listvisualizer.org. Do I have a volunteer? And trust me, this is super fun. It's really worth doing. So if someone can step up, I promise you it's going to be worth it.
I can do it.
Awesome. Thank you, Erin. All right, I'm going to stop sharing. If you wouldn't mind sharing a browser. Okay. All right. If you can, yeah, if you can blow up that screen, awesome. Thank you. Okay, we're going to talk about diarrhea, but why don't we do, can you click on the far right, causes of death, causes of child's 1 through 59 months mortality? Awesome. All right, pick anything but diarrhea. And hopefully all of you can appreciate how interactive this model is. And then hit isolate. So this is a pretty busy web page, but what you're going to see on the on the left-hand side is these are all the particular interventions. These are the risk factors that they impact. And then ultimately you can see causes of death. Okay. So if you can do me a favor, why don't we just go to things that directly impact meningitis? So let's go to the Men-A vaccine. Let's just talk about a vaccine, okay? If you can take your cursor, actually even better, let's do the pneumococcal vaccine. So that top box that you see on interventions, so instead of clicking on it, take your cursor and click on the line that connects pneumococcal vaccine to meningitis, and it turns red. So click on that. So I just want everyone to just stop for a second and this is what's so powerful about this webpage, okay? Not only does it tell you the efficacy of this particular intervention, but on particular, and it's not here, right? But on particular interventions, it will tell you what affected portion of the population that die from this cause can benefit from this particular intervention, right? And it shows you where the data is. It directly links it to the scientific literature that proves that there's a benefit to this particular intervention. So one of the things, and let me just bring it back home, right? When I'm spitballing ideas in the emergency department about how to get our care to our patients faster and safer, increase patient satisfaction, increase all these things that are important to us in our tiny little pocket of the world, right? I can throw ideas out there. It's sometimes really difficult to figure out where the evidence is. We have to do a lot of work, right? And if you think globally, there's billions and billions of dollars of investment going into making things better, to reducing mortality. There is a place where we can come to find evidence around this that has been compiled, that's easy to access for anyone, whether we're medical professionals, public health professionals, or the general public. And that's one of the really important things about tools like this, right? Is that we share information and do it in a way that's digestible so that we can get the interventions out there. I talked about how there's solutions for a lot of the problems that we have identified. It's now a matter of implementation, okay? So Aaron, thank you so much for sharing it. I'm going to just take you through, let me share my screen again. If I can. Zoom, where'd you go? Okay, with me? Nodding? Okay, awesome. Thank you. All right, so we're going to do diarrhea. So I'm going to just take you through, if I was doing this live with you, we'd click on mortality, and this is, again, how to use this. That pop open this page, causes mortality in the bottom right. I would click on diarrhea, and then I would click on the arrow for zinc. It would show you that the efficacy is about 0.23, with the ideal being 1, or perfect being 1. The effective fraction, that number of 1 is a little bit, that would imply that every single child should be given zinc treatment. I would need some time to really understand that. I didn't quite understand it when I saw that, so full disclosure. But I think this is a little bit more realistic. So ORS, this is really powerful. So oral rehydration solution, right? Usually it comes in sachets, and you mix it with water, with a fixed amount of water, and you can administer it to even a very young child by spoon if needed. And it shows that in terms of reducing mortality is 0.93. So about 93% effective. The affected fraction is the number of diarrheal cases that are susceptible to treatment by ORS. So we're largely talking about infectious causes of diarrhea. Okay. If there aren't any, are there any questions about that? Has anyone had their mind blown? I mean, Aaron and Teresa, you're the only two on videos. I can't really tell. But if anyone else is, give me a thumbs up. Jasmine, thank you. Anyone else? Cool. Yeah. That's a really wonderful tool. And if you haven't logged on to that site, definitely do so. I'll give you the web address a little bit later on in the presentation. Okay. I want to show you, this is in 2000. Really, I talked about care delivery. So these were the interventions that had some of the highest levels of coverage worldwide. So breastfeeding, and this is what we would consider complementary feeding, not 6 to 24 months, but 6 to 11 months. It was about 90%. The measles vaccine, about 68%. And compare that, and exclusive breastfeeding, you'll see at the bottom, at 39%. That's worldwide, but regionally it was a lot lower in certain areas. If you look in the far right, so nevirapine and replacement feeding for children born to HIV-positive mothers, that's about 5%. Insecticide-treated malarials, that was about 2%. So anti-malarials, I should say. And some of these other interventions that had just emerged, such as the Haemophilus vaccine, 1%. So you can see there's some that are easier to deliver, easier to message, that we have higher levels of coverage 20 years ago versus very low rates of coverage. And this is in 2010. What this is meant to show you is that interventions, they are interventions that are applicable from pre-pregnancy all the way through childhood. We're better at some interventions in terms of coverage levels versus others, and there's always opportunity to improve. Okay. So why is it that we aren't ramping up levels to where they need to be? I think a common argument is the cost. Frankly, what would it cost to deliver this kind of care? So in 2005, this group studied what would it cost to improve 23 known effective interventions in those 42 target countries that accounted for 90% mortality. And if you assume 99% coverage, right, that is an unbelievable level of coverage. In fact, most of our coverage targets are 90%, right? But what they estimated is annually what it would cost to get to those children and reduce mortality in those areas would cost about $5.1 billion annually. Okay. Worldwide, $5.1 billion. And that would amount to about $887 per life saved. That would have, I don't have the number listed up here, But that would, actually the citation listed, but that's what it would take to reduce 5 to 6 million deaths per year, right? So this is not a question of money in my mind. If you think about where our budgetary priorities are as a country and as a world, right? And this is based off of some scientific projections, but the argument that it's too expensive to provide implementation doesn't hold water in my mind. This is essentially talking about the number of deaths that could be averted if you brought these levels of intervention up to about just even 80% of coverage, and what the total cost could be. So this is slightly different data, slightly different costs, looking at different countries, not only the target countries, but again, this is saying that about $6.7 billion could save about 1.4 million deaths if we did just these interventions. You'll see that some of these are a little bit more costly. For example, there's the pneumococcal vaccine, Haemophilus vaccine, the rotavirus vaccine. Those have different costs associated with them. But I'm going to show you another amazing website in just a second that helps us factor in how we pick our priorities. So I need another volunteer here. And one thing I might mention is, for that next volunteer, I sometimes have problems accessing this website using the VPN. So if you can't log in, I might ask you to disconnect from the VPN, but you should still be able to stay on the Zoom meeting. So I'm realizing we don't have a ton of time left. Do I have a volunteer? Why don't I do this, actually? If you don't mind, if everyone could just take a note of this this web address, list.spectrumweb.org. And I'm going to take you through some slides that already demonstrate what the site does, but I do want everyone to play around with it at some point in the future, okay? So it will take you to this webpage, and this is an extension of the work that the Live State Tool Working Group has developed. Explore data is another way to see what's happening within a region, within a country, but missed opportunities is the place on the webpage that I want you to go. And what you can do is you can select a country, and then you can select you can select the outcomes in neonatal and children. I find this is actually the easiest way to look at these slides. It gets a little bit busy afterwards, but your choice how you want to select it. And then in the top right hand, you can't see it because it got cut off, but there's a cost button, and the cost button activates these little boxes. So what you can see is the intervention cost is given on this x-axis up here, and it correlates to this box. And on the bottom, you can see that the blue bars, these bars indicate the number of deaths that could be averted. So if you had full supportive care for prematurity, right, this is the number of deaths that you could avert within Afghanistan. Sorry, 14,000. 14,000 deaths. The cost, you'll see when it hits zero, it means that there's not an accurate or reliable cost associated with it. So it's a little bit harder to make a determination on that. But say, for example, full supportive care for neonatal sepsis and pneumonia, that would cost about $10 million a year, and that would save about 6,000 lives. So if we could just, I think it's really hard to put ourselves in a mindset of limited resources, and yet that is sometimes thinking about where you're going to prioritize your efforts. That is a part of quality work, right? Identifying the interventions that are feasible for you to do, that are going to be high impact, where you consider what the cost of that is going to be. There are tools available, and this is one of those tools where decision makers can think about where they want to allocate their resources. And I just want to show you, this is Afghanistan. And I picked these three countries because they're within the region and have high absolute numbers and high overall mortality rates. This is Pakistan. So full support for care for prematurity, full supportive care for neonatal sepsis. It's pretty similar to what it was for Afghanistan, but ORS here is a bigger intervention. And you can see proportionally that cost is actually, for $40 million, we could save about 25,000 lives, right? That's a significant impact that could be made. The costs are going to change within India being a more populated country. So that's so fascinating. Delayed cord clamping, essentially, that's a very low cost intervention, even though that box is around zero, but the number of lives that are estimated to be saved are about 40,000. You'll improve your neonatal survival. So just really simple things, versus now I'd mentioned malnutrition. So treatment for severe acute malnutrition, the number of lives you can save would be still substantial, 15,000. The cost, because oftentimes this requires hospitalization, is very, very high. And it's also really difficult. Even after hospitalization, survival is not guaranteed. So these are just things to think about in the idea that our challenge isn't so much the knowledge base around what works, but it's how to deliver that care and making those really important and sometimes difficult choices. There's one more conceptual model that I always mention kind of at the end of it, just to say that there are people working on this, even within our own institution and within our PEM faculty. So if we think about the three major delays in care, there's the delay in recognition of illness severity with, oh my gosh, my child is sick. There is the delay in transport to a facility. I need to get my child to a health facility or a healthcare provider. And then upon arrival, delivery of adequate care for that child. And so we have PEM faculty. I know Annika is on this call. So Carol Chen is working on nursing education. Annika is working on triage work. And Nick Lom is also working on pre-hospital systems and emergency medical services. But these are all interventions that are happening, that have happened, work that's being done to improve health systems and reduce overall child mortality. I want to leave you with, again, the same thoughts, the same summary. Under-5 mortality is the lowest it's ever been. There's been huge progress. And we know that there's disparities in terms of where under-5 mortality is highest. The solution isn't necessarily the same in each country or even within a region within a country. But one of the things that we should really take home is that there are interventions that are evidence-based, that are effective, that the challenge now is providing those interventions and operationalizing a lot of that work. These are kind of the future opportunities and threats. We could spend a lot of time talking about it, but there's work in front of us. There are also destabilizing factors to consider, the impact of climate change in particular, and how that might change our progress or impede our progress in reducing childhood mortality. On the right, this is an image of the report that I leaned on pretty heavily to prepare for this year's update. It's a wonderful 90-page document that is just so fascinating to read cover to cover, and it's really well written. So if you have the time, I definitely recommend it. These are some of the websites, the top three: the bizhubhealthdata.org, listvisualizer.org, listspectrumweb.org. I'll leave this up here for just a little while, and I'll take questions now, but feel free to screenshot it. Oh, and the one thing I should also tell you is the UN publishes an annual report. If you just Google UN child mortality, it lands you on a page with this report and a couple of interactive graphs that are interesting to work with. And then the Lancet publishes the Child Health Series annually. And then I think biannually, they offer a big overview of what's happening worldwide. Questions? Observations?
You have one official mind blown in the chat.
Yes. Thank you, Kim.
Were the current things you talked about with delay and like triage, delay in transportation, are those things that people are working on at UCSF or globally or both?
Oh, that's specifically what's happening at UCSF. That's work that Annika's doing. It's Nick Lom is doing, Carol Chen is doing. Those are three people within PEM that are the most active on global health work. And so those are people you can reach out to if you're interested in collaborating with them. And I'm volunteering you, but yeah, they're doing really inspiring work that I think would be great people to talk with.
And a comment from Annika. I know Raj only touched briefly on his background, but he's an excellent resource for learning about career options and how to integrate global health concepts into your work locally. So she just nominated you right back.
Yeah. Also happy. Annika's helping me quite a bit with something that we're working on to reach community hospitals in Northern California.
Very cool. Well, Well,
How much difference do you think the Helping Babies Survive program is making? It is making so Helping Babies, I think Helping Babies, is it called Helping Babies Breathe or Helping Babies Survive now? I forget. But that is specifically an NRP related neonatal resuscitation program like program that's being developed and implemented worldwide. And that is having a dramatic difference. I don't have data, but that was a big focus of the AAP about 2 or 3 years ago. And just the real impact it's made on reducing intrapartum or peripartum birth mortality. Oh, thank you. Yes, thank you, Annika.
I just went to an AAP conference where they talked about it. I'm not super familiar with all this, but I think the idea is like it's expanded beyond breathing to like all of the essentials you need for newborn survival. And they actually have, if you go to AAP, they have and WHO both, there's a ton of free resources. Like if you want to start a program or like integrate these concepts, they have like all kinds of resources for prepping that.
that's great. Thank you. We've also put in the chat a link to the survey. If you wouldn't mind, it takes just a minute and we do appreciate your feedback and revise things year to year.
Everyone, thanks for being here. I'm going to put my email in the chat. Anyone, feel free to reach out to me if you have any questions or if you just want to talk or think about how to map out a career. I'd love to be one resource of many that you can access here at UCSF.
Thanks, Raj.
Yeah.
Appreciate your time.
Yeah. Thanks for the
Okay.
invite. Thank you, Annika.
All right. Thanks, everyone. For the residents, we'll see you tomorrow.